Welcome back to another episode of the Sound Relief Podcast, where we explore the science, stories, and solutions behind what we hear, and sometimes what we wish we didn't hear. I'm your host, Dr. Julie Pretzman, and today's episode is a special one. If you've ever experienced ringing in your ears or know someone who has, this conversation is for you. Tinnitus affects millions worldwide, yet treatment often feels like the wild, wild west. Today, we're cutting through the noise, literally, with one of the world's leading experts on tinnitus, Dr. James Henry. Dr. Henry has spent over 35 years in tinnitus research, securing over 28 million in funding and changing how we understand and treat auditory disorders. He's also the founder of Ears Gone Wrong, his corporation, which has released 4 recent books that Dr. Henry wrote to make the science of tinnitus more understandable, even hopeful. We'll dive into his research, his initiative to standardize tinnitus care, and we'll hear about his motivation to keep writing books directed specifically to people experiencing tinnitus and sound hypersensitivity. So let's get into it. Dr. Henry, before we dive into the science, I always love learning about our guests. So what's something about you that might surprise others? Maybe something beyond your research and the books you've written.
Well, let's see. So I have tinnitus, I have loudness hyperacusis, I have hearing loss, and that's the hearing loss for sure was caused by playing loud rock and roll music in my younger days. So I grew up playing guitar. I played guitar in bands. I supported my family playing guitar, and I finally gave it all up. And then I became a carpenter, and I was a carpenter for 4 years and exposed to a lot more noise. And those were the times when we didn't know anything about ear protection. So I wasn't protecting my ears. So I did serious damage to my ears because of the loud music and the carpentry. And then I went back to school in audiology because I have a daughter who's deaf. That's what brought me to Portland, is a special school in the Portland area for deaf children, and that got me interested in audiology. And I went back to school and ended up at the VA hospital doing tinnitus research. So that's kind of what got me here.
Wow, I didn't realize that. That's very interesting. Yeah. I think a lot of people can relate to your noise exposure, right? Since that's probably one of the top causes of tinnitus, even today, even with great hearing protection options out there on the market, huh? So, yeah, I'm sure a lot of people can relate to that. And yeah, I didn't realize that your daughter had hearing difficulties or challenges with hearing. And I think a lot of people are attracted to this field of audiology because of personal experience with a loved one, maybe that has hearing loss or experiences something like that. And so that's very interesting. Thank you for sharing that. If we look back on your decades of tinnitus research, was there ever a moment where something unexpected jumped out at you, where you just kind of said, "Wow, I didn't see that coming," or was the research more kind of predictable, expected?
So in my doctoral program at Oregon Health and Science University, I was in Dr. Jack Vernon's lab, and I was there for 6 years. And so I was privy to their masking method, and they were really pioneers in this area. That's what triggered my interest in tinnitus. And then the
Mhm.
next sort of milestone was attending Dr. Jastreboff's tinnitus retraining therapy course in Maryland. I ended up doing a lot of TRT research, writing books about TRT, and then probably the next milestone was discovering that TRT was very difficult for a lot of patients to understand, and I do strongly believe in TRT, but for the VA and for veterans and for efficiency, we needed a more efficient program that wasn't so time consuming. And even though we got great results with TRT, we developed the method of progressive tinnitus management, or PTM, which is a stepped care method, which was really more efficient for VA clinics. And those are kind of my three big areas of of change. Just learning about tinnitus, getting excited about it, and wanting to do research, and realizing how much research needed to be done. And then Jastreboff has had a huge influence on this whole industry. I greatly admire the work that he's done, and then we developed our own method to be as efficient as possible for people with tinnitus.
Yeah, yes, I can completely relate to what you're saying. I also attended Yastreboff's TRT course at Emory back in 2002, and back then it really opened my mind to how much time it really takes to be able to, like you're saying, educate a patient on the neurophysiological model of tinnitus, because it is quite complex, and it requires several follow-up visits to really make sure that the understanding is there
Hmm.
for the patient. And so
Yeah.
um, it makes sense to me then how that would lead into progressive tinnitus management. So did you really feel that progressive tinnitus management, or PTM, was a little bit more practical in terms of being able to implement for patients, because it's like you say, it's a little less time intensive?
Yeah, I think practical is a key word for VA audiology clinics. A lot of them don't feel like they can even add tinnitus management to what they do because they're so busy taking care of veterans who have hearing loss. And so this method really does simplify things. The basic evaluation of a person with tinnitus is really simplified. And then if they do need further services, they move up to a structured counseling program. We even put everything on video so that if clinicians didn't have time to do the in-person counseling, they could make these videos available to their veterans. So the whole system was just streamlined to make it really efficient and practical for VA audiology clinics.
And was there research? Do you believe that the TRT method and the PTM method are equally as effective and equally as successful for patients?
I believe so. We've done controlled studies with each. We've done TRT studies, we've done PTM studies, and we've gotten good results with each. I think there's a number of methods. Cognitive behavioral therapy can be effective. Rich Tyler's tinnitus activities treatment can be effective. TRT can be effective. PTM, I think it's a matter of the provider and their level of competency and how much they understand the technique that they're using with their patients. And I think in general, patients can get a lot of benefit from any of these methods, depending on the provider.
Mhm. Right, right. So the key there is the provider. Do you think it's the provider being able to explain the complex in simple terms, or is it the provider being able to relate the material to the patient's symptoms, or combination of all of it? What do you think leads to the most successful provider ability to help somebody with tinnitus? What do you think that
Yeah, so
is
audiologists aren't
exactly?
typically trained in their AUD graduate programs, unfortunately. Hopefully, that will be changing in the near future. So
Mm,
they don't come out of their program typically knowing a lot about tinnitus and what to do about tinnitus, and often there's this fear that people with tinnitus, they just don't know what to do. But once you learn the basic principles and learn it's a disorder that I would say is very different for different people, and different people need different levels of services. And in fact, the statistic that's thrown around is that about 80% of people who experience chronic tinnitus aren't really particularly bothered by it. Now, they do need their hearing evaluated because they probably have hearing loss, and they often blame their hearing problems on their tinnitus. So it's really critical for anyone with chronic tinnitus to have a hearing evaluation. Find out if you also have hearing loss, but also find out if your tinnitus is bothersome enough to warrant receiving treatment. And that's kind of that stepped care approach. You go in for that basic assessment, figure out what's going on with your hearing, figure out if your tinnitus is bad enough to warrant treatment, and then move on from there.
And how would you explain to patients? You're right. This is so common. We have a lot of patients that say, I don't care about my hearing loss. I really think that my hearing loss is made worse by my tinnitus. And so if I didn't have my tinnitus, if you just treated my tinnitus, I feel like I would hear better and I could just ignore the hearing loss. What would you tell those people that strongly feel that the hearing loss is causing their tinnitus? What would you say to them?
I would say it's the hearing loss that's causing the hearing problems. It's not the tinnitus that's causing the hearing problem. Now, tinnitus can distract us, can make it difficult to concentrate. So, if we're trying to listen to somebody talk and we've got this loud tinnitus going on, it may be difficult to concentrate on the speaker. And that's what makes it so common for people to blame their tinnitus for their hearing problems. They don't realize they have hearing loss. You test their hearing and you show them the audiogram and you show them this dip in the high frequencies and go, that's the reason you're having trouble hearing. It's not the tinnitus. Now, I'm not ruling out tinnitus as being a factor in making it difficult to hear, but I would say in 99% of the cases, it's the hearing loss that causes the hearing problems and not the tinnitus.
Right. And, I've always found in my experience that if we ignore the hearing loss, when neuromonics, for instance, when neuromonics was more popular when it came out, I would have many patients who had high frequency hearing loss, didn't want to treat the high frequency hearing loss, but wanted to attempt sound therapy using the neuromonics system, which had the 4 tracks of music like signals that were just calming and soothing to the nervous system, help distract the brain away from the tinnitus. We had great results with neuromonics, but then once they were phasing off of using the sound therapy, it seemed in quite a few cases, I would say the vast majority of cases, that their tinnitus would then kind of start to increase in intensity again, because we never addressed, in my mind, some of the underlying issue, which was the high frequency hearing loss. So then I would say to these patients that were saying, okay, well, my tinnitus isn't as loud, it's still there, and I'm still straining to understand, my wife clearly. And so then after a year of using neuromonics, we'd end up having to say, well, we need hearing devices, we need amplification, we need hearing aids at this point. So did you see that also in your research, that ignoring the high frequency missing input, as I like to think of it, was never going to, ignoring that piece of it was never going to give them maximum benefit or maximum relief? Did you find that to be true too?
So the whole concept of hearing aids and tinnitus is important because hearing aids alone can be beneficial for treating tinnitus because of the enriched sound environment that it creates. That's the whole principle behind tinnitus retraining therapy, sound therapy with TRT, is to enrich the sound environment, and hearing aids enrich the sound environment. So as long as you're wearing your hearing aids, you're reducing the contrast between your tinnitus and ambient sound. So hearing aids alone can be helpful for tinnitus. And then you can add in they may have sound generators built in. In fact, most of them do these days, and they have streaming capabilities. The hearing aid becomes a tinnitus treatment device. You can stream from your smartphone to your hearing aid. You can turn on the sound generator. You've got the amplification. So I'm a big believer in the use of hearing aids for tinnitus management, even for people who aren't necessarily hearing aid candidates. They might not be ideal candidates to address hearing loss, but they have all these other features. And there is this concept of mild gain. Just turn the gain up a little bit on the hearing aids to just amplify sound a little bit. All of those things can be helpful for people with tinnitus. So I'm not sure if that answered your question, but that's my basic feeling about hearing aids and tinnitus.
Yeah, no, I totally agree that, I think at least 50% of the time, amplification might be enough for someone with bothersome, persistent tinnitus. And so it's definitely worth trying amplification alone. And then if, as you're saying, if they could benefit from additional sound therapy, so many of these devices have such great features to be able to, like you say, stream or turn on these wave-like sounds or fractal tones. There's so many different options today that can really help calm that nervous system down and distract the brain away from the tinnitus. And I mean, it can be really powerful and impactful for people, even, yeah, like you say, even with just mild hearing loss, because if you apply that mild gain, like you're saying, I found that in background noise, even because a lot of tinnitus patients with even mild hearing loss complain of not being able to hear well in background noise. So I think it's nice to see technology today that can really address, all three issues: the mild loss, the trouble in noise, the tinnitus. But I think one element that's confusing for people, and you spoke of this when we talked about your personal experience. What about the patient with hyperacusis? Because I know patients with sound sensitivity think, no way are you going to be able to put a hearing aid on me because I'm already sensitive. And if you amplify things, you're going to make me more sensitive and it's going to make my tinnitus worse. So, how do we explain that to patients?
Yeah, that's a difficult one. So I have hearing loss and loudness hyperacusis, and I have done everything I could possibly do to reduce my auditory gain. Basically, auditory gain is the volume control in the brain, and our brain adjusts that volume control according to how much sound is coming in or not coming in. If people who like to be in quiet environments, they don't have so much sound coming in their ears, so that volume control gets turned up and they become more sensitive to sound, and they're only exacerbating their hyperacusis problem if they have hyperacusis. So if you have hearing loss and loudness hyperacusis, you're right. You put a hearing aid in and it's amplifying sound and everything is too loud. And that's exactly the case for me. And I have hearing aids, but I often don't wear them because sound is too loud. Now, hearing aids can be adjusted so that the maximum power output is limited, and it can be limited to within the range of comfort for that individual. So I would not steer people away from hearing aids. In fact, I'm getting a new pair, and I'm gonna do all the things I'm talking about doing right now, because there are instances when I know I need my hearing aids and I don't have them. So I'm doing what I'm saying people should do is
Mm-hmm.
get the hearing aids, but get them adjusted so that the maximum power output does not see the level of comfort, so that the sound is
Mm-hmm.
always within that comfortable range. You never want it to exceed that comfortable range. So it's just a matter of the hearing aid, the audiologist, being aware of this
Mm-hmm.
and working with the patient to make sure that the hearing aids are staying within a comfortable range when they amplify.
Right. Yeah. I think with, digital technology, compression, there's so many different ways we've found that can work. I've worked with hyperacusis patients where we basically start with negative gain, so we have a closed
Mhm.
dome. So we're really controlling all the sound input. We're controlling the output by really compressing everything into almost a zero gain situation, but then slowly, very, very slowly opening up that range for them over time. And you can see patients, we usually use the analogy of physical therapy. If we give you 1 pound to lift, and then 3 pounds, and then 5 pounds, and slowly increase your tolerance, it can really work. But you have to have the persistence and mindset of, okay, this is going to be a little bit of hard work at first, because I'm not super comfortable with the concept of amplification. But if people understand, like you're saying, Dr. Henry, that we do have the control to maximize the upper end, and try to just give a little bit of gain for soft sounds, minimize the gain for loud and average, really keep that envelope narrow and small, and then over time desensitize their system and try to open it up. And it can work. It definitely can work, but it's not a quick fix. It's not overnight. It's not a snap of the fingers. And you're right, you have to work with an audiologist who understands that concept, and who, we can't set these patients to real ear targets using our Verifit 2 equipment day one, or they will never touch the devices, never be able to wear them. But that would be the ultimate goal. In maybe like a year's time, maybe we could get to real ear targets eventually, and we have seen that to be successful. But it is a challenge, and I think it's Would you say sound hypersensitivity disorders are about as understood as tinnitus? Because, again, I don't think we're spending enough time in our doctoral programs on these topics. Would you agree with that?
I think we know a lot more about tinnitus than we do about sound hypersensitivity disorders. And I just wrote that book on hyperacusis and misophonia, and I did a pretty deep dive into the literature to see what has been written about these disorders and how they're defined, how they're described, what's being done about them. And it's a far more complex topic than most people realize. Even audiologists and physicians, they don't understand the distinctions between all of these disorders. The important thing is that people with tinnitus often have loudness hyperacusis, and if they have loudness hyperacusis, the key to treating loudness hyperacusis is to adjust that auditory gain. And it can usually work for people if they bring more sound in. They're adjusting the gain to where they can tolerate more sound. And what you're describing is perfect. You've got the right idea. Start off even with negative gain, and just little by little by little turn it up. You're never making the patient uncomfortable with sound, but
Mhm.
you're increasing their tolerance to sound little by little over time, and that generally works for most people.
Yeah, and it's sometimes hard for patients to understand because I think it might be counterintuitive, right? They think I'm sensitive to loud sounds. I'm more sensitive than everyone else out there. So I'm going to wear my, earmuffs or my earplugs in the car just to go to the grocery store. And what is actually happening is they're making the auditory gain in the brain even more far off from what we consider to be normal because now they are overprotecting their hearing in day-to-day activities. And so, you know, sometimes step one isn't even the device, right? Step one is we just need you to stop wearing the hearing protection so frequently
Hmm.
because we're never going to get devices with amplification. And it's fascinating to me because a lot of those people do have hearing loss. They don't recognize or realize they have hearing loss. They just think I'm so sensitive to sound, I must have perfect hearing, when in fact it's the opposite. So it's always amazing to me how complex our auditory system is, and from the ear to the brain, everything in between is so complex. And that's why I think, like you're saying, your books are so important because there's not a lot of information out there to explain, what's really going on with these complex auditory issues. But that's one of the first steps, really, is with hyperacusis. I think is especially for people overprotecting their hearing is trying to explain why that's not going to work long term. They're just going to get more and more sensitive if they continue to overprotect their hearing, and that could be really challenging because then they feel like they can't leave their house or do anything out in public.
It's a real
Yeah.
balancing act between how much should you use ear protection and how much should you make sure you have sound coming in your ears. And that's where the counseling is so important to help patients understand they do need to protect their ears if sound is too loud. And they do need to protect their ears from sound that can be damaging to their ears. But other than that, they need to keep the earplugs out, the earmuffs off, and be exposed to sound as much as possible. Never uncomfortable sound, always enjoyable, interesting, soothing sound that they like, and
Mhm.
start getting accustomed to being in an enriched sound environment. So not only is sound therapy good for tinnitus, but it's good for loudness hyperacusis. So it does double duty for people who have both.
Mhm. 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 And what is your simplest explanation, if there is one, for why hyperacusis occurs? Why does this happen to people?
Well, so the concept of central auditory gain is usually, and this is theoretical. We don't know for sure, but I would say most researchers agree that when we get hearing loss, we have less input going into the brain. And when there's less input going into the brain, that increases the spontaneous activity of the neurons in the auditory system. And a lot of people refer to it as overcompensation. It's saying the input's not coming in, so we're going to turn up the gain. And so that could be what's underlying tinnitus, and it could be what's underlying loudness hyperacusis.
Hmm. Hmm. Yeah, and it can be so counterintuitive, I think, again, for people because they think I'm more sensitive, so I must have better hearing, and it's always usually the opposite. And then I remember, I can't remember if it was mainly Yasserbov's work. I'm sure other people have also seen the same thing, but I've always thought of loudness hypersensitivity, loudness hyperacusis to be present in about 25% of people with tinnitus. Does that number still ring true, or do you think we have different data today?
I don't think we know because the definition,
Okay.
people call all any misophonia, noise sensitivity, phonophobia, all these
Mhm.
different disorders, they
Mhm.
lump them in under hyperacusis. And they also
Mhm.
don't really do a complete evaluation. If somebody is annoyed by children's voices, do they have hyperacusis? Probably not. If they're
Mhm.
annoyed by squeaky, there's certain sounds just annoy them. Does that mean they have loudness hyperacusis? Not necessarily. So I think we've
Mhm.
overestimated the number of people who have loudness hyperacusis, and then people who have misophonia are lumped in to the hyperacusis category. So we just don't have good epidemiological research to know how many people with tinnitus also have loudness hyperacusis or misophonia or any of these other sound hypersensitivity disorders.
Yeah, I no, I totally agree. Weekly, we have patients coming into the clinic that I think have self-diagnosed themselves because they've done some research maybe online and come in and say, "I have tinnitus and hyperacusis," and we'll say, "Okay, tell me more about that." And oh, I just can't stand, the always high frequency sounds. I can't stand, my wife emptying the dishwasher. I can't stand my grandchildren's voices, all high pitch. But it's only related to the high frequencies where they have the notch in their hearing, usually probably similar to the center frequency of their tinnitus pitch match. And so it's interesting to think about because, yeah, I think a lot of people are, like you say, just kind of lumped into hyperacusis, but it's just maybe three or four specific sounds. And honestly, if you can give them compression for the high frequencies with amplification, oftentimes they stop complaining about those sounds. And so, which is a good thing. But yeah, I think it's been hard because a lot of people have been just lumped into hyperacusis when it's probably more recruitment or, like you say, maybe misophonia in some instances. So that's tough. But how are we going to fix that? How are we going to improve our ability to really diagnose properly the differences between recruitment, hyperacusis, misophonia, phonophobia? What is it going to take? Do you think, in your mind, for us to be able to diagnose these specifically sound hypersensitivity disorders more accurately?
Well, education is the most important thing. Audiologists need to be educated about what the different disorders are. We developed an instrument called the Tinnitus and Hearing Survey that is valuable for if a person is blaming their tinnitus for their hearing problems. It helps to separate those two issues out. And then we also screen for a sound hypersensitivity disorder with just two items at the bottom. It takes just a few minutes to complete the Tinnitus and Hearing Survey, and it provides a ton of information. But when you screen for a sound tolerance problem, you need to know what the different problems are so that so that if the patient says, well, this kind of sound bothers me or that kind of sound, the audiologist knows, well, maybe it's this or maybe it's this. And also, does a full evaluation need to be done? And if a full
Mhm.
evaluation needs to be done, we have the sound hypersensitivity interview, and that's all described in that book. And then you need to sit down with the patient and go through that interview question by question by question. And at the end of that interview, you'll know. An audiologist who knows the different disorders will know what disorder or disorders the person has. And then the treatment would be the next step after that.
Mhm, mhm. So really kind of tackling it one piece at a time and getting more information, more specific information from the patient about the sounds that are bothersome, um, to be able to understand how to best help them, really.
Yeah, and to determine if they really have a disorder or not. I mean, that's why screening is
Mhm,
important, and an
mhm,
audiologist who's educated will know that, well, this person probably does have a disorder and needs a full evaluation. Then you schedule that evaluation, and that can take up to an hour to really talk
Mhm.
through everything and figure out, does the person have a sound sensitivity disorder or not? And if they do, then
Mhm.
they need some kind of treatment. And that's the stepwise approach again, but it kind of takes them in a different direction. I mean, if they have tinnitus, they can go one direction. If they have a sound hypersensitivity disorder, they go another direction. Sometimes they need
Mhm.
psychological care if they have misophonia, because that's really an emotional reaction to sound. Loudness hyperacusis is a physical reaction to sound. Misophonia is an emotional reaction to sound. So those are two different things.
Right, right. And yeah, I think misophonia for sure is the least understood, or that we have the least amount of providers out there able to help patients with misophonia. I feel like they definitely had a spike in misophonia post COVID, and I think
Mm,
that was related to the isolation and not being around each other, and then we got back with each other, and so we had kind of a spike in requests from patients with symptoms similar to misophonia. But um, yeah, it is very complex and takes time to really tether through to understand, is this just a temporary reaction, or is this like you're saying, a disorder that needs more involved treatment? But have you found for misophonia and hyperacusis that some of the very similar principles from TRT and PTM can help those patients as well as tinnitus patients?